So let's talk about how you would look at a child with cough, presenting with cough. Yeah. So what would you be looking for, Hon?
So first of all, I would look for the duration of the cough. When does it start? And then how long does it last? And then does it happen like particularly at night or not? Which might give me some idea of what's going on. And then
Okay.
next one will be like severity.
Okay.
So severity I can like from a scale of 0 to 10.
Mm-hmm.
Yeah, so this is severity can also give some clues. And then next one is like contact history. If there's any contact history, especially like in nowadays we have COVID-19, so the contact history is very important. And then we have to ask about the treatment. So if there is any treatment that has done beforehand before the patient has come over to the doctor. And we also want to ask some associated symptoms other than cough, maybe like fever, which can give me some idea about infections or some like either post-nasal drip, which can give me some idea as well. And lastly, I will also ask like if there is any vaccinations done before. So
fantastic.
Yeah. So yeah, I think that's all from me.
Okay. So anything you need to add?
Maybe we can look at the quality of the cough also, like if it's a dry cough or a productive cough.
Okay.
Then maybe you can look to see if the patient has any sounds of breathing.
Okay. So Hong actually is doing like a little bit of history taking, right? But all the time when you're taking a history, then you should actually be looking at the patient, yeah? Especially pediatrics. We don't have time. A lot of time they may cry and then everything will be huru hara. You know? So what we do is usually we will, for me, usually from a distance, I see who the patient is. Okay, is it a young child or is it an older person or adult? Older child. Huh? So first of all, what age? Okay, 1. Because that will affect my differential diagnosis. For the older person, I will have to worry a little bit more about the smoking history, environmental exposure, allergy, COVID, you know. Whereas the younger one, newborn, then I worry about newborn history, the birth history, admission history, sibling history of allergies, and so on, so on, and so on, so on. So the age is very important. So one is that the patient, who is the patient? And then secondly, who is with the patient? So sometimes the stories they're brought by a relative, so the story may not be 100%. So that may affect a little bit about the diagnosis sometimes because the story. So who brought the patient and who is the patient? And then I want to know where is the patient. So for instance, you get a call in the middle of the night and the patient is from the mortuary, it's a mortuary attendant, then you know it's a dead, it's brought in dead. Maybe COVID case, I don't know, but anyway, brought in dead. So I always say that doctors have to know alive or dead or half dead. Okay? And that is very important, especially pediatrics. Dead is tough, but you know, we will have to do something about. But if they are still alive, then every minute counts. You run, okay? You really run. So the timing, alive or dead. So you see how the patient is brought in outside. They can come by themselves, walking happily, and the child is still running around and playing. You know that it's not too bad. But if the child is like very lethargic and want to sleep and irritable and not happy at all and coughing or whatever, then you know that, you know. So that this is what we call a helicopter view. So always have a helicopter view. Huh? So who came? Who is with the patient, and then how is the child? Alive, dead, or what in between? Okay. So then and then only then you look at the child in terms of color, Okay, overall color. And because if they are looking cynos, you don't want to take a long story and try to, you know, like have a relative who was admitted terminal cancer and very, very breathless, hypoxic, like, you know, the very purple. And the MO was still asking long stories, you know. Then you say, no, you better put the oxygen on, do the treatment first, and then deal with the whatever story later. So be very careful with when you take a long time, taking a very long history, you have to make sure the child is stable first. So nowadays with our pulse oximeter, it's very nice. You just clip it on, it looks okay. We can talk. So if it's a child, does a child look pink and sinus or whatever, huh? And then you look at they listen for the sounds of breathing, which can be starting from the nose, grunting. So they have this nasal flare, which tells you that there is a lot of wet. The lungs are very wet, and the child is trying to auto CPAP, to try to open up the airway. Yeah. So if you hear a lot of grunting, or you hear wheezing, or if the aspirated case, sometimes they have sound, and so on. So sounds of breathing. The voice is very useful. They talk a lot and very clear and happy and so on. It's okay. If they're very breathless and halfway they have to stop talking, like some of the very breathless, so that could be severe asthma. So again, you might have to intervene quite fast. So these are the before you. Then in the meantime, of course, when they're watching, then you are asking all the stories, and then you can actually examine the patient. Okay. So examination of a pediatric case starts when the child is quite far. So that's why now when we manage patient and we're managing from a distance, a lot of parents are wondering how come you don't examine the chest, or how come you don't use the stethoscope at all now, They're a bit worried, like, what type of medicine is this? you know? So actually for most of us consultants already, we more or less can make a diagnosis even without handling the patient at all. Because by the time we ask the patient, we listen, we look at the way the child breathes. So there's the recession, signs of breathing, signs of heavy breathing. So in recession, suprasternal, intercostal, subcostal, abdominal breathing. So these are all signs of respiratory effort. So by the time I see that, even if you hear the lungs, nothing, I don't hear anything. It's what they call silent lung. It's very dangerous. And asthma, you really have to worry. Or even if I don't hear anything, it doesn't matter, because I have to treat as definitely a lung issue or maybe an aspiration. Okay. Yeah. So pediatrics, you really a lot of time the consultants, like I will not allow my patients, my students to handle the case until they have told me, all this up to this point. Then only then they start listening. Okay. Yeah. So that is cough, examination of cough case. So examination of cough case, not just listening to the chest. Of course, in examination, when you're doing a short case, long case exam, then you have to play by ear with the how you've been trained and how they like it done, because sometimes they think you are like wasting time when you're standing there describing and not examining. So in exam situation, then you have to go into some of these YouTube videos where they give you from A to Z the steps, great detail. Now you will follow that. Yeah. But for the practice, in practice, usually helicopter view, alive, well, or dead. Okay. Yeah. So, okay. So the story is quite, Hon has given quite a full story. Okay. So examination of a cough case.